Hello, welcome to the short where we're talking H's and T's, that list of things to review and double back on when you're on a run, kind of scratching your head, not sure what to make of it, or maybe you're on an arrest and you just want to ensure that you have addressed everything that can potentially be addressed. That's where H's and T's come into play. And it's just a list of things that start with H or T. We'll start with H, hypothermia. Which patient temperature? What is your patient's temperature? Have they been outside for a prolonged amount of time? What's the temperature outside? Is it wet? Are their clothes wet? Were they in water? What's the temperature of the water? Is there a current in the water? All those things are relevant. If they are hypothermic, take them out of that environment, take wet clothes off, start rewarming protocols. Hypothermia. Next one, hypovolemia. Has your patient lost a lot of blood or fluid? Were they dehydrated? Was there trauma that preceded blood loss? That can begin to be addressed in the pre-hospital with IV fluid management and blood potentially on where you are and what your protocols are. Hypovolemia. Next one, hypoxia. Is your patient hypoxic? Do they have enough oxygen circulating in their system? Is there an airway issue? What's their breathing like? Are they breathing adequately? What's their breathing rate? What's their level of effort? Are they showing accessory muscle use? Are they in the tripod position? Are they hypoxic? That can begin to be addressed in the pre-hospital setting. Next one, hydrogen ions, and I have in parentheses acidosis. So this pairs really well with hypoxia actually. When our patient is hypoxic, they are forced to shift into a new gear of metabolism called anaerobic metabolism. And anaerobic metabolism is like the backup plan for when your body doesn't have oxygen and it's forced to make energy with what resources it does have. Now, it does work, but not that long and not for long, and there are consequences to doing that. One of those consequences of that chemical reaction is hydrogen ions, and hydrogen ions have a low pH comparatively to your body. So the higher concentration you have of hydrogen ions, it's going to pull you away from homeostasis towards acidosis. Acidotic patients are known to be difficult to resuscitate, and that can begin to be addressed in the pre-hospital with potentially some sodium bicarb. Hyperkalemia, and then I have hyper underlined here because that is going to be the one that is going to have the highest consequence potentially for that patient. Now, we do not have the luxury of labs in the pre-hospital setting. I think some services might, but that's not something that we do locally here at this time. So there will be signs, okay? You have to collect a whole picture of your patient. What is their history and what am I seeing in front of me? Big one, the big hits for hyperkalemia are going to be renal failure. Does my patient have a kidney injury? Is it acute or is it chronic? Either way, if the kidney's not working, it's not filtering out potassium, raising potassium levels in the body. They're going to stack. They're going to get high. Has your patient a dialysis patient and perhaps they've missed? That's not uncommon at all in the pre-hospital. We run on people like that all the time. How many appointments have they missed? 1, 2, 3? The more they miss, the greater the consequences of doing so will be. What this could look like also, other than dialysis patients or chronic renal failure, it could be a crush injury as well. Did your patient experience a traumatic injury where maybe they had a large amount of potassium building up in the body and then it circulates into the kidneys after that crush is released, after that pressure is released, and is it causing an acute kidney injury? What's your ECG look like, all right? Do you have wide QRSs? Is it slowing down? Is your QRS bleeding into your P wave and into your T wave? Are they bradycardic? Are they hypotensive? Do you see a sine wave? These are all signs and symptoms of hyperkalemia. That can be addressed with calcium. And again, if you're not sure, get on med control, talk with a doc. Tension pneumothorax, onto the T's. Does your patient experience trauma? What do your lung sounds like? Do you have unequal lung sounds? Listen to your heart tones. Are they muffled? Do I see jugular vein distension? Tension pneumothorax. That can begin to be addressed in the pre-hospital with a needle thoracentesis. Tamponade, cardiac tamponade. What's going on with your heart? Listen to heart tones. Are they muffled? Do I see jugular vein distension? Do I have a low blood pressure? Is there a history of infection? Are they on antibiotics? We in the pre-hospital cannot necessarily address this, but this can be something that can be addressed in the hospital. Say, for example, you are on a cardiac arrest, PEA, pulseless electrical activity, and then you listen to the heart and you just hear kind of a muffled heart tone. There's a good chance that that patient they might want to see them in the hospital because they can potentially address that. Toxins, think an OD. This could be anything from illicit drugs like heroin, fentanyl, all the way to organophosphate poisonings. Is there something inside the body, like chemically, that is not supposed to be there? And can you address it? Potentially. If it's an opiate, yeah, Narcan all day. If you're not sure how to address it, call poison control. I've never once called poison control and regretted doing so. They're always super nice, super helpful, and really like it when people like you call them and ask for help. And they do a really good job of also contacting the emergency room and give them a heads up on what's going on. It just helps you out. Toxins, and last one being thrombus. There are two types, the cardiac and pulmonary. Is there a potential that there's a thrombus lodged in the vasculature of my alveolar space or on my coronary blood vessels? What's my 12 lead look like? Has my patient been traveling for a prolonged amount of time? Are they on multiple blood thinners? Do they take them regularly? Do they have a history of AFib? Gather a history. Again, in the pre-hospital setting, we're very limited in what we can do, but some of these things can be addressed in the hospital, and we all work together to take care of our patients. That's H's and T's. If you guys have any questions on those, please reach out. I'd love to talk to you about it. Thank you.